All right, let's just jump right into it. Today's explainer is a rapid-fire test of your clinical instincts on high-yield surgical complications. No fluff, just the pearls you need to know. Picture this. You've got a 73-year-old patient who just rolled out of emergency surgery. It's only been 30 minutes, and suddenly, total acute confusional state. Your pager goes off. What's causing this? We've got to think fast about those critical first 48 hours post-op.
It's hyponatremia. Why? Because acute post-op delirium that hits this early, we're talking literally minutes to hours, is almost always driven by metabolic or electrolyte disturbances. Hyponatremia causes neuronal swelling and cerebral edema, which leads directly to that altered mental status. And here's a massive pitfall. While hyperactive delirium gets all the attention because the patient is thrashing around, hypoactive delirium is incredibly common and gets missed all the time.
So your absolute reflex here? Early post-op confusion means you check electrolytes first, especially sodium. Do not start chasing complicated neurological diagnoses before you've looked at a basic metabolic panel. It's got to be automatic.
Okay, next scenario. Your patient spikes a fever on the second post-operative day, exactly 48 hours after they were closed up. What's the most likely culprit?
The answer is atelectasis. Think about the physical reality of a patient recovering from surgery. In that 24 to 48-hour window, they are in pain and they're lying still. And what happens when it hurts to move? They take shallow breaths. That lack of deep inspiration leads right to alveolar collapse. Boom, pulmonary atelectasis. It is far and away your most common cause for a fever, hitting right at that 48-hour mark.
Lock this golden rule into your brain. Second-day fever means you check the lungs first. Now, if that fever hits after 72 hours, that's when you pivot. You shift your thinking straight to infections, surgical site infections, UTIs, pneumonias, or anastomotic leaks. When it comes to post-op diagnosis, timing is literally everything.
Next up, your patient is waking up from anesthesia, and they are shivering violently. And hey, this isn't just about them feeling cold, this is a profound thermoregulatory dysfunction. What medication are you going to push to terminate this?
You're going to use intravenous ketorolac. The mechanism behind this is fascinating. Post-anesthesia shivering is driven by thermoregulatory dysfunction, and NSAIDs like ketorolac actually work by reducing prostaglandin-mediated thermogenesis. But why is this an emergency? Because shivering massively spikes the patient's oxygen consumption. We're talking 100 to 200% increase. You have to shut that down fast. Now, classically, mepridine is considered the best drug because of its kappa opioid effect, but NSAIDs are a fantastic alternative, especially when there's an active inflammatory component.
All right, let's look at the gut. What is the most common manifestation of acute gastric dilatation after surgery?
It's massive vomiting. Here's what's happening. After surgery, patients can develop gastric atony. The stomach basically just loses its tone. This causes extreme distension, which then forces the lower esophageal sphincter to stretch out and become totally incompetent. The end result? Effortless, massive vomiting.
And you've got to act fast. This requires immediate life-saving intervention. Your move is to drop a large-bore NG tube to decompress the stomach. But you have to be hyper-vigilant here. The lethal risks, if you ignore this or botch the management, are massive aspiration and severe vagal bradycardia, which is triggered by that extreme stretching of the stomach wall.
Let's shift gears to intraoperative risks. What is the specific benefit of placing a patient in the lithotomy position?
It actually means fewer chances of damaging the obturator nerve. It sounds counterintuitive, but when you flex the hip beyond 90 degrees, you actually reduce the tension along the obturator nerve pathway. This significantly decreases the risk of a traction injury while they're on the table.
Let's contrast these nerve risks so you never get them mixed up on an exam. The femoral nerve suffers from compression right under the inguinal ligament, and that actually gets worse with hyperflexion. On the flip side, the obturator nerve is protected by flexion, but it suffers a stretch injury with excessive abduction, specifically anything greater than 30 degrees. Oh, and just to round out the whole pelvic neighborhood, don't forget the sciatic nerve, which risks stretch injury from pretty much any extreme positioning. Moving right along, which statement is correct regarding day case or outpatient procedures? It's all about selection. Good preoperative selection and assessment is absolutely required. Listen, success in ambulatory surgery isn't about how fast the surgeon is. It entirely depends on picking the right candidate. To keep complication risks low, your ideal patient has to be stable, have minimal comorbidities, and they absolutely must have a strong support system at home.
All of that, plus strict anesthesia clearance, is what gets them out the door safely.
Okay, let's plunge into a highly specific metabolic crisis. What causes hypoglycemia in a diabetic patient immediately after a below-knee amputation?
It's a sudden decreased requirement for insulin. The physiology of source control here is just incredible. Think about it. When you surgically remove infected or gangrenous tissue, you abruptly shut off the massive load of stress hormones like cortisol and catecholamines that were flooding the patient's system. This causes a steep, sudden drop in their insulin resistance. So if they're still getting their previously high infection-adjusted dose of insulin, that dose is suddenly wildly excessive, and it'll crash their blood sugar straight into hypoglycemia. You always have to adjust insulin post-op in diabetics.
Let's stick with systemic infection for a second. Which of the following is not a metabolic response to sepsis?
The lie here is a decreased nitrogen requirement. Sure, increased cortisol, glucose intolerance, and lipid oxidation are all true responses, but sepsis is a profoundly hypermetabolic and highly catabolic state. It actively ramps up protein breakdown, which leads to a massive loss of nitrogen. So sepsis actually causes a negative nitrogen balance. That means the body's nitrogen requirement goes up, not down.
Pivoting to a classic endocrine complication. If a surgeon accidentally removes the parathyroid glands during a neck dissection, leading to sudden hypocalcemia, what is the earliest objective sign you're going to see?
You're looking for carpopedal spasm. Trousseau's sign, which presents as that classic carpopedal spasm, is significantly more specific and shows up earlier than Chvostek's sign. It is hands down the most reliable early objective marker for sudden hypocalcemia. Just keep in mind, hypomagnesemia can perfectly mimic this, so you always need to double-check your labs.
Now, right on the heels of that, what is the early sign of latent hypocalcemia?
It's a bit of a trick question, because the answer for unmasking latent hypocalcemia is also carpopedal spasm, elicited by Trousseau's sign. Let's contrast this against tingling, because that's what trips people up. Tingling of the face or extremities is indeed an early symptom, but it's entirely subjective. The patient just feels it. Carpopedal spasm, on the other hand, is an objective, specific, and totally reproducible diagnostic sign. Knowing the difference between a subjective symptom and a reproducible clinical sign is exactly how you beat these trick questions.
So, the next time you step onto the surgical ward and a diabetic patient's blood sugar suddenly plummets post-amputation, or someone starts shivering violently right after anesthesia, how will you apply these clinical instincts to intervene and save a life? Take these high-yield facts, get out there, and stay sharp. See you in the next explainer.